So I am doing the last actually recorded lecture for our class for our Res 221. The next one will be live on Friday the 7th. So this is for Tuesday the 4th. Alright, so I went ahead and I postponed your exam until Friday also because this material will be on that exam. Alright, so make sure you look at chapter 13 out of Wilkins. So we're just kind of talking about taking care of the older patients, things that we need to kind of consider. Okay, so trying to communicate sometimes with these patients can be a little challenging, but if we take our time and make sure that they understand what we're saying to them, it definitely helps. Keeping in mind that older patients have a depressed immune system and can often present with atypical signs and symptoms. So the graying of America, they call it, increases the importance of understanding the needs of the patient population. So they're estimating by the year of 2030 the population of older adults is likely to increase to 72 million from 39 million in 2008. So of course I imagine COVID's probably taking a little toll on our aging population. We as RTs deal with the aging population of most of our COPD patients because it's a chronic disease. Of course, people that have started smoking earlier, we actually even see COPD patients as young as their later 30s, for sure in their 40s. Let's see. Also, as we broaden our scope of practice, meaning like, we're working in different facilities such as home care, possibly pulmonary rehab, nursing homes, and that we need to consider that population that we'll be working with. So again, chronic disease and aging can result in abnormal normals. The depressed immune system puts these patients at risk for greater infection. We need to be more aware of any functional disability that could impact their respiratory status. For example, patients that might be in a wheelchair or wheelchair bound, they often, or if they're slumped over in a chair, not having proper posture, that can lead to difficulty breathing. Sometimes working with our PT and OT department can help give us some options to help them. And 50% of patients needing respiratory services are generally 65 years of age and above. Just some little tidbits there. Avoid ageism. Ageism is considered a discrimination against the aged. Treat the aged with compassion. Never assume that because a patient is a certain age or from a certain place, like a nursing home, that they will all be a certain way. No matter what, always talk to your patient. You cannot always assume or know what they feel or what they hear. Keeping in mind of some of the different barriers with communication, sensory deficits, including hearing or visual impairment. Speech may be impaired, like my speech is always impaired, by poor fitting dentures, stroke, head injury, or Alzheimer's disease. You may encounter emotional barriers such as depression. So we have to figure out what works for these patients to help make our communication better. Try to always address your patient by the last name and appropriate title. I do know that one of the areas in our chart will say preferred name, or they often have their name written on that whiteboard when you first walk in the room. That kind of helps you, because sometimes they have a nickname that they prefer to go by. But you can always say Miss or Mr. Of course, Mrs. is always kind of assuming that they're married, but I feel fairly comfortable calling them by their first name if that's what is listed in the chart, and also what's on the whiteboard. Some patients really get upset if you call them sweetie or dear. They consider that to be condescending, so just be kind of aware of that. I've had maybe a couple people say, don't call me that. You want to make sure that the lights in the room and any heat adjustment or whatever to make the patient comfortable, because that always makes, if they're comfortable, they're more willing to communicate with you. Always introduce yourself. These are things that we went over in regular patient care too. Explain your purpose of your visit. Try to eliminate any background noise and interruptions. Sometimes that includes turning the TV down. Maybe ask them if it's okay. So just don't go into the room, no matter what age really, and just assume that the place is yours. Be respectful of their space. And definitely with elderly patients, don't rush them, okay? They really don't like that at all. You need to be present in that moment with your patient, focus on them, their disease, and their treatment. Some of the other hearing impairment then is something, proboscis or whatever, is age-related progressive hearing loss, often caused by diminished functional independence. They also could be suffering from tinnitus, I think. Ringing or buzzing in their ear is more prevalent. It can be caused by ototoxicity or earwax. If they suspect earwax, sometimes the nurse might be aware of it, and they may try to possibly remove it, but that would be upon a doctor's order. If they have a hearing aid available, make sure that they have that if they need it. Sometimes assess hearing impairment by whispering a simple question while out of view but close to the patient. Yeah, I don't know. I think that's kind of inappropriate because they might think you're talking about them, but ask the patient if, I think I accidentally got these slides mixed up here for a second. So ways to compensate, ask the patient if they can hear you okay. Ototoxicity could be a cause, or again, that earwax. Adjust the hearing aid or ask them if they need their hearing aids. Enunciate the words clearly and slowly. Make sure they can see your lips, which I know is really hard now with wearing the mask all the time. Sometimes you need just to kind of get up close to their ear and just talk very slowly and specifically. Another thing they suggest is you could actually put your stethoscope earpieces in the patient's ears and speak into the bell. That's kind of, I don't know if I really do that either, because you never know how clean their ears are. That's kind of, some of them have amplifiers that they wear, which kind of acts like that. It kind of hangs, it'll be in their ear, an earpiece will be, and then they'll have like a little box that you can speak into. Vision impairment, so just making sure, and again, most of these impairments, of course, you could be the first person or one of the first people to see these patients, but they'll often have it noted that they're hard of hearing. HOH is kind of a acronym, hard of hearing, or they'll have a note on their chart or on that whiteboard or some other type of sign that kind of indicates that they might have a hard time hearing or seeing. Well, making sure that they have their glasses if they need them. Not really something that we are assessing per se, but just being aware making sure that they have things near them that they need, like their call light. Patient, like this says, just kind of leave everything where the patient wants it. They tend to memorize where things are. Making sure labels have large letters, or if there's puff paint, there's different type of lighting available if they need it. Again, just being aware if they're, that things are kind of out of their way, if they need to get up, or if they need their walker, if they have their call light available. So those are just things to kind of take in consideration. Considering the cardiovascular system, that's definitely a common issue with elderly patients, presenting as increasing systolic blood pressure as we age, increased left ventricular afterload, then is going to result in left ventricular wall thickening. So you're thinking that the left ventricle has to push harder against that pressure, and then it makes the left ventricular wall thicker. Arterial walls stiffen as we age. By the age of 80, your left ventricular filling can slow by 50%. Up to 90% loss of your SA cell numbers. So 90%, that's crazy when you think about it. So that's your primary pacemaker of your heart. So if you're losing those cells' functionality, you're going to have a higher risk of having increased cardiac arrhythmias, especially atrial fibrillation. That's a pretty common arrhythmia that patients get. The occurrence of congestive heart failure doubles for each decade of life between 45 and 75. I always get so depressed when I do this lecture because as I'm aging, I'm like, oh my God, that's nice. How our organs though age varies from person to person. We spend a quarter of our lives growing up and 3/4 of our lives growing old. Of course, remembering that lifestyle choices, environmental factors, and genetics all play a role. So it's not all doom and gloom. Some is obviously out of our control, but some of it is in our control. So take good care of yourself. Here's just kind of comparing left-sided heart failure versus right-sided heart failure. Left-sided heart failure, exertional dyspnea or orthopnea, possible nocturnal dyspnea, chain stroke breathing, pale, cool skin, arrhythmias, fatigue, restlessness, irritability, shortened attention span. Sometimes I feel like I have all those. No, I'm just kidding. Right-sided heart failure then is associated more with edema, so you think of the backup of the system, distended neck veins, cyanosis, dyspnea, arrhythmias, hepatomegaly, and occasional ascites. And of course, our pulmonary system ages also. So our trachea and bronchi become more rigid. Our smooth muscle progressively is replaced with fibrous connective tissue. So your lungs become more stiff and less compliant. The alveolar septa gradually deteriorates, which the alveolar septa, gradually deteriorates. So you lose that definition between the alveoli, which then reduces the surface area for gas exchange. The alveolar capillary membranes thicken, which reduce diffusing ability. Our lungs again have that less elastic recoil. The chest wall itself become more rigid. So we have an increased FRC and a residual volume. Also keeping in mind that as you age, you're more likely to get, kyphotic, which in that sense can actually attribute to more restrictive lung problems. So at 55 years of age, our respiratory muscles begin to weaken. The diaphragm strength may be 75% of a normal healthy adult at age 55. Your cardiac and pulmonary responses to decreased oxygen and increased CO2 diminish with age, so your body's not quite as aware of it as you age. So again, the age-related changes aren't too terribly significant until they're combined with a disease. So that together increases your risk of morbidity and mortality. So again, just like anything else, an illness or a disease, I mean, if you get sick, the flu, pneumonia, all these things, COVID, all these things you're at more risk of as you age, because your body isn't in the shape that it used to be to help you compensate for and to recover from these illnesses. Also, the epithelial lining of your tracheobronchial tree degenerates, your ciliary action slows, and the phagocytotic activity decreases. Your cough becomes less effective. Your muscle strength goes down, especially for a lot more older people. So that decrease of the cilia and then the muscle strength decreases your ability to clear your secretions, which makes you more susceptible to your pulmonary infections. Institutionalized adults mean patients that are like long-term care facilities, like a nursing home or skilled nursing facilities. They're even more susceptible. They usually have conditions that might lead to decreased level of consciousnness. Possibly, they have agitation, confusion, dementia, and that, and they may have increased use of narcotics or sedatives to kind of keep them safe, so they're not falling. GERD, dysphagia, difficulty swallowing. Of course, all of that is related to increased risk of aspiration, and then along with your decreased ability to cough. So aspiration, choking, dysphagia are definitely concerns in our older patients. And then our immunity. Our immunity decreases as we get older. The ability to fight infections put us at greater risk for pneumonia and sepsis. Increased frequency of reactivation of TB. So there's a term called immunosenescence, which is the aging of the immune system. So it's IMMUNOSENESENCE. So IMMUNO, immuno, and then SENESCENE. It's basically the aging of the immune system. Alright, so people present a little bit differently. Older people present from illnesses compared to younger people. Some people can just write off symptoms and that of just old age. They have decreased peripheral sensitivity, diminished pain receptors, so they're more likely to get burned. They may not realize if their hand is touching a hot surface, for example, until it's too late and they've gotten a fairly severe burn. Their reflexes are just not there as they used to be. Tachycardia response to hypoxia and sepsis is reduced, so where a younger person may be tachy with being hypoxic or septic, older people, they may not present that way. So they're a little bit kind of harder to kind of figure out. And again, as their organs age, they start losing their ability to help compensate for whatever else is going on. They have a diminished inflammatory response. So pneumonia may not present like shortness of breath or decreased SAT so much, or increased heart rate and all that, or even they may have a cough, but it might not be as hard of a cough or pronounced as a cough. They may have more just kind of a generalized symptoms that could be symptoms of many different things. So that's why it's really important to do all the workups of getting a chest x-ray and getting their labs and that. So they may have reduced appetite, they might just feel tired, not being able to perform their daily activities, just overall weakness, could possibly have nausea, vomiting, diarrhea. They might have a little bit of an increase in their respiratory rate. That's the most sensitive sign, is having an increased respiratory rate. The chest x-ray might not even actually show an infiltrate if they're dehydrated, and that's definitely a thing. I can remember with older people, if they're dehydrated, if they're dry, it might take a while for them to rehydrate with IV fluids before an infiltrate will actually appear. Consider a bronchoscopy if you can't identify the cause of what's going on with them. Some studies show that about 75% of Americans are chronically dehydrated. So your typical presentation would be like a cough, a fever, purulent sputum, and their symptoms are going to be a lot more subtle in older adults until it's much more severe. They may not seek medical attention until they're kind of far into the process, which makes treating them more challenging also. So heart failure. Heart failure is a leading cause for hospitalization of people over the age of 65. 50% of people older than age 75 years of age die of an MI. Again, they often have atypical presentations. Could be complaints of shoulder, throat, abdominal pain, even bilateral elbow pain. Could be syncope, kind of a syncopal episode where they just passed out. Acute confusion, weakness, fatigue. They could be dizzy, short of breath. Might only be their complaints. Cough, wheezing, hemoptysis. So they may not have the typical, standing on the chest, elephant on the chest, the squeeze, the pressure, like older people. Dizziness, you definitely want to suspect a heart problem. So I don't know if I told you guys, but my stepsister, passed out a couple months ago and got a good gash on her head, but she had gotten up in the middle of the night and wasn't really feeling good, was kind of nauseated, kind of had some GI stuff going on, and then she ended up go to stand up, and she just passed out. So they kind of worked her up for any cardiac stuff, which all turned out to be negative, thank goodness. All right. Asthma is often misdiagnosed. So we should consider asthma if an elderly patient has wheezing or shortness of breath, even if they don't have the nocturnal or the early morning symptoms where it would be usually worse. Even if they don't have a history of allergies or immediate response to bronchodilators. So it's often difficult to diagnose these patients too, because, well, we tend to have an underdiagnosis may relate to underuse of objective measurements by spirometers and peak flow meters, but taking in consideration also that these patients need to be able to follow directions well. The older, they might just be kind of overall symptoms of being short of breath. They may, and then you have to figure out, is it cardiac or is it pulmonary? And I know Victor has expressed frustration sometimes of trying to get 85-year-old patients to properly do a PFT, a pulmonary function test, because they just don't have the ability really to follow the direction and because a lot of that is, most of that exam, following directions and being cooperative and being able to perform the test properly. So sometimes that's a challenge when you are trying to do different tests on these types of patients. 5% of adults older than 60 can present with asthma, and 7 to 9% of adults older than 70 have asthma. So it can be, like kind of late onset. All right, looking at their temperature. we tend to be lower at greater than 90 years of age. Your temperature, your baseline might be only like 96 to 97. Getting a temperature on them, obviously we don't do a lot of temperature taking by mouth, but being able to keep their mouth closed, of course that old-fashioned way takes usually several minutes. Axillary method might not be accurate because of muscle wasting. The rectal method is accurate, but obviously not tolerated the best. The tympanic method is expensive but accurate and fast. I mean, that's pretty much, we don't really even use tympanic anymore. We use the ones on the forehead, those little scan things. So, important to establish a baseline and a trend so you can kind of see whether it goes up or down. So, generally, their body temperature is lower due to decreased metabolism, decreased muscle mass, and decrease in vasoconstriction. They may have an altered ability to control their body temperature. So vital signs as we're taking the heart rate. As we get older, our heart, hold on one second. So again, sorry about that, I had to go look at some. So an active older adult might have a normal resting heart rate, so like 60 to 100, but inactive ones may have a resting pulse of 50 to 55. So if we think about how the SA node of those cells are not as, have died off, and we go further down the electrical system, as we go further down, then we go to the AV node, then those heart rates are slower. So that may be part of it. Arrhythmias with rapid pulse are poorly tolerated, so we really want to try to slow them down because they're really going to end up having a compromised cardiac output. Blood pressure, again, this one actually rises with age, particularly the systolic blood pressure. Risk of cardiovascular disease actually doubles with every 20/10 increment. So every time your systolic goes up 20 points or your diastolic goes up 10 points. So it's very important to keep that blood pressure under control. Blood pressure may be falsely high because of arterial stiffness. They say to have the patient rest quietly for 3 to 5 minutes. Use a cuff that covers 1/3 of the upper arm or the bladder of the cuff. Measure blood pressure in both arms, see if there's any differences. Check for orthostatic blood pressures, supine and sitting, especially if you're coming across a blood pressure that you don't believe, that you want to investigate further. Respiratory rate, I just have a typo here. This should say 16 to 25. 16 to 25, and I'll go in there and fix this. Tachypnea may be due to if they just got up. A lot of times we get called to assess patients because they seem like they're short of breath, but they just ambulated, especially our COPD patients. Sometimes they really cannot tolerate that trip to the bathroom. You might recommend a bedside commode or something, because especially if when they were first admitted with their exacerbation and they're just still having a hard time, even sitting up at the edge of the bed, and they're, insistent on getting them up into the restroom. It's just kind of a nice, gentle reminder of maybe they would benefit from a bedside commode. Anxiety or mid-brain lesions, hypoxemia we need to be mindful of, acidemia or possibly a pneumonia. Bradypnea may be due to meds or being asleep, or an alkalosis or hypothermia. Checking out their breathing patterns. They may have chain stroke breathing, which might be a reason for, or caused by CHF. There may be uremia, respiratory depression, and brain damage. Biot's respirations are sometimes seen in elevated ICPs and brain damage. Make sure you're kind of noting the length of the apnea, if it's kind of cyclic, or how do they wake up, or we checking maybe these are patients that need to be on a continuous pulse ox. Cyanosis. Elderly may have small vessel syndrome with local areas of cyanosis and necrosis, so they may not be necessarily cyanotic, but just because of their vasculature and their circulation. They may appear pale or cyanotic at room temperature. Looking at their skin turgor kind of assesses hydration. It says tenting cannot be used because wasting provides a false positive. So what tenting is when you take their skin and you kind of pinch it, like on the upper part of the top part of your arm. If you pinch it and kind of hold it, and if it tense up, like it stays that way. Sometimes really thin skin, kind of dry, they may tent like that, and they're saying that that's a false positive. It's better to look at their mouth, their lips, and their tongue to really see if they have any moisture. Clubbing, again, elderly patients have a higher incidence of chronic disease, so they therefore have a higher incidence of clubbing. It might actually indicate some type of connective tissue disease. Edema. So being mindful of edema can also indicate heart disease. Just gathering some more papers here. So peripheral edema, so out in the periphery, can indicate possible CHF or DVTs, a deep vein thrombosis. DVTs generally have like pain and redness and that associated with them too. It also could be, it could be edematous from like a low albumin level too, so malnutrition, because that helps keep that onychotic pressure. JVD is usually indicative of right-sided heart failure. Hepatojugular reflex is a reliable indicator of heart failure in the elderly. That's where the physician generally pushes on their liver, kind of, and then you'll actually see JVD happen. Palpation in the elderly. So while we're looking at patients and attempting to do the palpation on them, you might also notice other skin conditions such as scars, signs of infection, presence of bumps or bruises. You'll see that kind of more often. It seems like their skin isn't quite as uniform. Oh my gosh, my dogs are barking again. So we need to be aware of those patients on vents or with trauma or post-thoracic surgeries, especially those that have chest tubes in. We want to check for subcutaneous emphysema. Evaluating for local phragmitis is going to require cooperations, and sometimes they're not able to participate. Pulmonary auscultation. Just keeping in mind with our COPD patients, that in itself can sometimes really be a lot of work for them. They might not be able to sustain that deep breathing, so they might have to rest. Start in the posterior basals again first, see if we can note any atelectasis or crackles. Sometimes they're hard to hear on these patients, especially our COPD patients. And our adventitious breath sounds are going to be just the same as any other patient. Bear has decided that he needs to come in and visit me. I kept getting distracted. He keeps scratching at the door. Brat. So diagnostic tests, again, sometimes these are definitely just a challenge to even do on our patients. They're going to have a reduced vital capacity, peak expiratory flow. They're going to have increased closing volume, which reduces ventilation to the bases, while increasing ventilation to the upper lobes. This is going to result in increased VQ ratio or mismatch. They might have a slight reduction in their PaO2 caused by, again, the loss of the alveolar surface area, which is going to increase the VQ mismatch. So that closing volume is the volume of the lung inflated when small airways and the dependent parts of the lung begin to close during expiration, and this creates air trapping. Air closure may happen on normal expiration and decrease ventilation to areas in the distal areas, which increases that VQ mismatch. Check out the table in chapter 13. Kind of just talks about how your PaO2 decreases with age, about 0.245 millimeters of mercury per year. A blood gas drawn from a supine patient has a PaO2 of 5 millimeters less than if a patient's sitting, probably because they're just breathing shallower and they're not taking as deep of a breath, so it probably makes a bigger difference in our elderly patients. After age 75, the PaO2 tends to be higher in males. The PaO2 should be adequate if there's no disease. Hypercapnia occasionally in healthy aged patients, not as predictable and usually mild. And then here again it's kind of showing, here's that table I was referring to, as you age. So at age 10, it's kind of when you have the perfect PaO2 of 100 there, and then it just kind of all goes downhill after that. See how I told you how exciting this is? Things to look forward to. Alright, the pulse ox. So generally the pulse ox, PaO2 is the lower PaO2 results in a lower SAT. So usually about 93 to 94. If the PaO2 stays at 60 or higher, the fall in the SAT's not going to be as significant. Make sure you have a good measurable pulse is essential to measure the SpO2. And again, with these patients that have poor circulation and they're just kind of colder, vasoconstricting, it's sometimes a little bit of a challenge to get a good reading on them. So if you do suspect anything and they're presenting with respiratory distress, or you just really can't get a good pulse ox, draw a blood gas. All right, more exciting numbers here. After age 25, your PFTs start to decline. Your residual volume almost doubles with older age, so that's why it's really important, especially when you're working in the PFT lab, that you get those normal values. They're all already computed in there, but it's important that you have accurate age, height in that. Your FVC and your FEV1 is going to diminish by approximately 30 mils per year for men and 23 mils per year for women. Your DLCO decline, not linear, but it definitely worsens after the age of 40. Again, like I mentioned before, the PFTs may require extra time on these patients so they can understand what you're asking them to do, and they just have to have several attempts, and then usually after about 4 attempts, then their numbers might not be accurate because they're probably tired and worn out from doing it. So it's definitely worth noting in your comments or talking to your pulmonologist on how their level of comprehension and how well they're able to perform the test. Here again are some other age-related test changes with your PFTs. This again on chapter 13. So comprehensive assessment, just making sure, questioning how are these patients doing every day. Are they able to do their ADLs, their activities of daily living? Are they able to take care of themselves, feed themselves, use the toilet, dress themselves? You know, all these become an issue. That's one nice thing with pulmonary rehab. They really can help patients like this because they have respiratory that helps them. They also have PT and OT come with these patients, so they can show them how to do these activities without getting too fatigued or tired, especially if that's part of their issues. Other things that instrumental activities would include, you know, are they able to still, you know, manage their money, use a phone, writing skills, ability to shop. All these things obviously deteriorate as you age, and just making sure that they're able to care for themselves or have someone to look after them. Case management is generally always involved when it comes to discharging our patients, but our input's valued too if we really feel that something isn't going well for them or they're too compromised to take care of themselves properly. So a little bit of a summary here. Effective communication will definitely improve our patient care. Taking that extra time with our adults is worth the effort. Preventing disease, disease presentation is often atypical in elderly, and disease prevention would be really wonderful if we could do that. Vital signs and functional anatomy are often altered and aged. Preventative interventions to keep older patients healthy and functional at home is the best medical care we can offer. So, you know, making sure that they're able to take care of themselves, that's generally when they're the happiest. So that does it for this lecture.